So someone asked about ventriculoperitoneal shunts in patients who have glaucoma. And this is an interesting question because it raises all sorts of issues on what the pathogenesis is of glaucoma. As you know, most glaucoma is primary and open angle POAG, which means it's idiopathic. We really don't know what the cause is. However, one of the hypotheses for primary open angle glaucoma is that you have increased intraocular pressure higher than this person can tolerate, and it's pressing on the lamina cribosa, causing mechanical deformation at the junction of the optic nerve to the eye. Because that wall stress is felt more at the lamina cribosa, the ophthalmoscopic finding is cupping. However, there's a pressure on the other side of the sclera. That pressure is intracranial pressure. And so that translaminar gradient might be what is causing glaucoma, either an elevation of intraocular pressure, or in a patient who has a shunt, it could be a decrease in intracranial pressure. So the translaminar pressure gradient will be higher if you raise the IOP or if you lower the ICP. And that could lead to the mechanical deformation called ophthalmoscopic cupping. And so there is some evidence from the literature that patients who have glaucoma, normal tension glaucoma, actually have hypotension, intracranial hypotension from CSF pressure. And that is a fascinating theory of POAG. And so we might see worsening of glaucoma in patients who have a ventriculoperitoneal shunt. Whether this hypothesis is true or not has not been established in large enough studies to establish this connection. However, it is intriguing, and so in some of our patients who have glaucoma, who have progressive worsening despite normal intracranial pressure, intraocular pressure, we might dial up the shunt to correct the ICP if their symptoms can handle it. This is of theoretic value only right now, but it is an intriguing hypothesis.